Welcome to Revise Med. I am Dr. Rahul Vijayan. Today we will be seeing a new topic, that is retinal vasculitis, a rheumatologist perspective. So how you can approach a retinal vasculitis in terms of a rheumatologist view. That's we will be discussing. It's a bit lengthy topic. I will try my level best to make it a short one. So let's get into the topic. As per the definition of CERN working group, retinal vasculitis is defined as ocular inflammation with retinal vascular changes. What do ophthalmologists see in case of retinal vasculitis? They include perivascular exudation, perivascular sheathing, fluorescent leakage in case of FFA, that is fundus fluorescent angiography, and intraretinal hemorrhages and cotton wool spots. So as a rheumatologist, how we can correlate these ophthalmologist findings in case of a rheumatological context? That's we will be discussing in this session. So we will come with a systematic approach to this. So let's see. An approach towards any disease, history is the key. So we have to take a systematic medical history. First, our job is to assess the patient whether they are immunocompromised or not. If they are immunocompromised, think about infection first, especially CMV, HSV. They can be seen in case of, especially in case of AIDS, and those who are taking immunosuppressive drugs, they are more prone for this. So next is, we as a rheumatologist, we have to think about the rheumatological diseases which can have a retinal vasculitis picture. So you have to ask about recurrent oral and genital ulcers, which can be seen in case of Behçet disease, and chronic cough and constitutional syndrome. You have to rule out tuberculosis and sarcoidosis. In India, tuberculosis and syphilis is one of the most important causes of retinal vasculitis, and we have to always rule out TB and syphilis in all cases of retinal vasculitis. And in some case of sarcoidosis, you have to again look for the bilateral parotid enlargement as well as bilateral ankle arthritis, whether the patient is having any joint pain around the ankle or not. And systemic autoimmune diseases such as SLE, polyarthritis nodosa, GPA, that is granulomatous polyangiitis, can also present as retinal vasculitis. Coming to the drug history, you have to be very careful regarding some drugs, especially vancomycin. Vancomycin can cause hemorrhagic occlusive retinal vasculitis. If you are giving an intravitreal brolucizumab is an anti-VEGF molecule. It can also cause occlusive vasculitis along with intraocular inflammation. In order to diagnose any drug-induced uveitis, there should have a temporal association. Without any temporal association, never consider drug-induced uveitis. There must be an initiation of a drug which is going to precipitate this event. So there should have a temporal association. Coming to the surgical history, any prior history of a pars plana vitrectomy or a silicone oil injection can lead to toxic posterior segment syndrome, which can cause a retinal vasculitis. The mechanism for silicone oil induced vasculitis is through the low molecular impurities in this oil, as well as it acts as a foreign body and cause foreign body reaction. So coming to the examination proper, even though retinal vasculitis is a posterior segment involvement of the eye, the examination starts in the anterior segment, because correct evaluation or systematic evaluation of the anterior segment itself can give a clue to the diagnosis of the posterior segment involvement. So always you have to start the evaluation from the anterior segment. We are using slit lamp for the examination of anterior segment. In anterior segment, you can see keratic precipitates, especially fine capes, usually seen in case of non-granulomatous uveitis, especially in viral mediated diseases. In view of rheumatological perspective, it is fine capes are mostly associated HLA B27 associated, that is ankylosing spondylitis associated diseases. And you can see mutton fat capes in case of granulomatous uveitis, especially TB and sarcoid. And next comes the iris. In case of iris, you have to look for the nodules. Iris nodules can be also a clue for TB or sarcoidosis. In case of sarcoidosis, it will be associated with Cope and Bussaka nodules. And any presence of any posterior synechiae also will give a clue towards the sarcoidosis. And next is the intraocular pressure. Any high intraocular pressure along with an iris atrophy, you have to think about viral uveitis, especially HSV and varicella zoster virus induced. Both this HSV and varicella zoster will have a same phenotypic result or phenotypic manifestation, and they usually present with high intraocular pressure. So coming to the posterior segment examination, which is a core segment examination in case of retinal vasculitis, the fundus usually tells us a story, so we should be trained to read the necessity signs. So the key questions we want to answer by examining the posterior segment is which vessels are affected, whether it's an artery involved, whether it's a vein involved, or whether it's a both artery as well as vein are involved. Then is it a perivascular or intraluminal involvement, or are there any coexisting retinal or choroidal lesions along with this? So you should answer all these after the posterior segment examination. Fundoscopic clues after the examination. So perivascular cuffing usually seen in all cases of vasculitis and predominantly seen in cases of sarcoidosis, multiple sclerosis, and Eales disease can be associated with tuberculosis. Hairless plaques is associated with toxoplasma retinitis and cotton wool spots. Presence of cotton wool spots suggestive of infarcts. So usually seen in case of SLE, polyarteritis nodosa, EGPA. Aneurysmal dilatation usually seen in IRWAN, that is idiopathic retinal vasculitis, aneurysms, and neuroretinitis. And retinitis patches can be seen in case of Behçet, cytomegalovirus, HSV virus, varicella virus, and toxoplasmosis. And perivascular choroiditis. Presence of involvement of choroiditis, you should always rule out tuberculosis. So let's integrate the whole clues into a diagnostic algorithm to approach a retinal vasculitis. If a patient is coming to you, you have to take a history, search for any systemic illness, whether they are immunocompromised, whether there is history of any drug intake or a recent surgeries, whether they are on any immunosuppression or any diabetes or any or other immunosuppressive drugs. So these are more important. So after that, you have to start examination and you have to start the examination of the anterior segment. In anterior segment, you have to find out whether it's a granulomatous or a non-granulomatous. Granulomatous, they can have keratin precipitates, that especially mutton fat keratin precipitate and Irish nodules will be seen in case of granulomatous uveitis. Then you have to check for the intraocular pressure, whether it's elevated or not. If it's elevated, it's more suggestive of a viral pathology like HSV or varicella, and any Irish changes such as nodules or synechia. If they are present, rule out tuberculosis and sarcoidosis. And then you have to examine the posterior segment to look for which vessel type is involved, whether it's an artery, vein, or both, or any associated lesions such as any choroid or retinal patches or choroiditis is there. And you have to see any classic patterns in the fundoscopy such as Kyril's patches or Kyril's plaques, aneurysms, and cotton wool spots. Presence of cotton wool spots usually suggests systemic vasculitis or underlying masquerading diseases such as diabetes and all. So coming to the classification based on etiology, these retinal vasculitis can be classified into primary, that is idiopathic, and secondary, that is include infectious, non-infectious, neoplastic, and others. Among infectious, it include tuberculosis, syphilis, herpes, and toxoplasmosis. And non-infectious, it is Behçet syndrome, sarcoidosis, GPA. Neoplastic include lymphoma, leukemia. This retinal vasculitis can also be a manifestation of a paraneoplastic vasculitis. So you should keep in mind that the differential for retinal vasculitis as one of this malignancy also. Coming to the others, that is IRWAN and Behçet retinopathy also you can be seen. So based on vessel size, you can divide that retinal vasculitis is predominantly affecting small vessels, that is capillaries, and medium vessels, it is arterioles, and large vessels, that is central retinal vessels. And based on the clinical presentation, you can classify into occlusive versus non-occlusive and ischemic versus exudative. This is the classification based on etiology, vessels, and clinical presentation. So coming to the pathophysiology, pathophysiology is actually very simple. It is similar to all other inflammatory diseases. Inflammation occurring in the vessel wall causes damage and it causes increased permeability. So once there is an increased permeability, there you are going to have some leakage. So this leakage can be identified by fundus angiography staining. Inflammation also can lead to vasoocclusion leading to ischemia. Once ischemia has occurred, there will be neovascularization. This neovascularization can cause vitreal hemorrhage as well as traction retinal detachment. So this is the overall pathology that. So let's approach the retinal vasculitis in some detail along with the investigation. So when it to called primary retinal vasculitis, Before calling it as a primary retinal vasculitis, you have to do a thorough systemic workup, and there should not be any signs of infection, malignancy, or any autoimmune disease. So when to suspect a systemic disease or when to call for a rheumatologist for consultation is if the retinal vasculitis you are having is a bilateral disease along with any other organ involvement, and it's a granulomatous inflammation, especially sarcoidosis, to be ruled out, or any history of an ulcer, rash, or a fever, then you should suspect a systemic disease. Don't label it as idiopathic until every rock is turned. Especially, you have to rule out tuberculosis in India. Tuberculosis is a great mimicker in case of retinal vasculitis. So let's have an idea about the imaging in retinal vasculitis. Nowadays, the imaging in retinal vasculitis is more of a multimodal domain or multimodal imaging. Imaging is essential for diagnosis, staging, monitoring, and therapeutic planning in case of retinal vasculitis. As a gold standard, what we are using right now is the fundus fluorescein angiography, that is FFA. Emerging tools such as OCT angiography. If you are having any contraindication for fundus fluorescein angiography, you can use OCT angiography. And ultra wide field imaging and adaptive optics. The concept of multimodal imaging is not just for seeing inflammation. We want to understand more of its extent, the perfusion status, and its complications. So we are now preferring the multimodal imaging method. So let's look one by one in detail. Fundus fluorescein angiography is now considered as the gold standard for retinal vasculitis. Its key role is to detect whether vascular leakage is there, to monitor macular edema. But now we are actually using OCT to assess the macular edema, which will give a more accurate measure of this edema rather than FFA, and to assess capillary non-perfusion areas, and to identify optic disc leakage as well as neovascularization. The pattern of vascular inflammation from FFA is very crucial. We have already discussed regarding the etiology based on vessels. So this FFA will give an idea regarding which predominant vessels are involved, whether it's veins, arterioles, or capillaries, or both. If it's a predominant phlebitis, that is venular and veins are more predominantly involved, then the differential predominant will be Behçet disease and tuberculosis. And arteriolitis, you should have a differential of viral vasculitis in your mind. Most of the cases will have viral vasculitis as the cause for arteritis or arteriolitis, and other autoimmune conditions like SLE should also be ruled out, and ANCA-associated also should be ruled out. And in case of capillaritis, it is predominantly small vessel vasculitis. Even in that case also viral vasculitis as well as ANCA-associated should be ruled out. So FFA based staging of retinal vasculitis can be divided into 4 stages. That is, one is active inflammation, which include fuzzy perivascular infiltrate, hemorrhages, and cystoid macular edema and vascular leakages. In ischemia stage, you can see capillary dropout, sclerosed vessels, collateral formation, and neovascularization stage, you can see fragile new vessels, and there is an increased risk of vitreous hemorrhage. And sequelae and complications such as tractional retinal detachment and neovascular glaucoma also can be seen. Think of FFA as a time-lapse storytelling of vasculitis, that is, from the stage of inflammation to ischemia, and from ischemia to fibrosis. So what are the key markers on FFA? We have already told that in FFA you can identify vascular leakage. Suppose you are seeing a diffuse leakage, think about Behçet, TB, and sarcoidosis. And if you are seeing a segmental leakage, think about multiple sclerosis, sarcoidosis. Sarcoidosis is also often associated with skip lesions. And if you are seeing a fern-like capillary leakage, it is commonly seen in case of Behçet disease as well as intermediate uveitis. You can also see macular edema in case of FFA, which will be characterized by late phase dye pooling. But normally we are now using OCT to detect or assess macular edema. And optic disc hypofluorescence can be also seen in FFA. Late leakage on FFA is a marker of inflammation. So it is important to distinguish optic disc neovascularization from it. Next is the retinal ischemia and capillary non-perfusion. This can be seen in case of tuberculosis, Behçet, Eels disease, SLE, and viral vasculitis. Anything which are going to affect the vessels, you are going to have an ischemia over there. You can use FFA to assess the non-perfusion area, ischemic maculopathy, and it's also an indication to start laser photocoagulation in the patients. And retinal and disc neovascularization also can be seen by using FFA. This neovascularization is through VEGF mediated angiogenesis, and it can cause complications such as vitreous hemorrhage and tractional retinal detachment. So FFA guides the treatment decision whether we should start a laser photocoagulation or steroids alone for this patient. If you are seeing predominant non-perfusion areas or high risk for a neovascularization, then you should be planning a laser photocoagulation in that area. So what are the special consideration in FFA interpretation? Peripheral leakage means it's a biomarker of poor disease control. Especially in case of Behçet, clinical examination of patient may be normal, but FFA will reveal that they are having fern-like pattern or inflammation. And occlusive vasculitis in case of tuberculosis or viral etiology can be missed out without FFA. And macular ischemia may not show structural changes, but it can cause a permanent visual loss. Coming to the OCT and OCT angiography, OCT is used to assess the macular edema quantification and to assess the cystoid changes. And OCT angiography, that OCT means optical coherence tomography. It's a non-invasive capillary plexus visualization, especially when fundus angiography is contraindicated. In optical coherence tomography angiography, they are using some light waves to reconstruct the vessel anatomy, and they are not using any dyes or injection, which usually we are using in case of FFA. And it is used to assess the ischemic maculopathy and early neovascularization. Next is the ultra wide field imaging and adaptive optics. Ultra wide field imaging allows imaging of a far peripheries, especially in cases of Behçet disease and Eales disease. In these cases, usually the periphery of the retina are involved rather than the central part. You can use ultra wide field imaging. When you are coming to the acoustic optics, it enables to assess the cellular level details. This is actually experimental and gives out a high resolution results. So coming to the treatment and correlative part, you have to always suspect infection at first. Always rule out infection before assessing the other causes. Because all of the other causes, the treatment is going to be mostly associated with immunosuppression. So you have to rule out infection at first before treating others. To rule out infection, you have to look for syphilic serology, that is VDRL and TPHA, and toxoplasma, IgG, IgM, and tuberculosis in skin test and IGRA. Especially in India, you have to always rule out tuberculosis. Tuberculosis is the great mimicker in India. Always tuberculosis and syphilis should be ruled out in any case of vasculitis. And if you are again suspecting an infectious etiology and all clinical signs are suggestive of an infectious etiology, you have to do PCR from the ocular fluid to look for herpes simplex virus infection, 1 and 2 varicella zoster infection, CMV, toxoplasmosis, and tuberculosis. You can also try serology in blood itself, but the serology test in blood is less sensitive. So why you want to do a PCR? Culturing the ocular pathogens is extremely difficult, and PCR detect DNA or RNA directly even at low levels. It also helps to differentiate the virus with similar phenotype patterns, especially in case of HSV and varicella zoster virus. So PCR is not just about diagnosis, it also helps to monitor the treatment response also. Coming to the treatment principles, as I told earlier, if it's an infection, treat the infection first, that is treat ATT for tuberculosis and penicillin for syphilis. If it's a non-infectious etiology, you can use steroid, that can be used topical as well as systemic depending on the clinical setting, and you can start immunosuppressant if it's a autoimmune pathology. You can start methotrexate, azathioprine or MMF, and biologicals are indicated for Behçet, especially infliximab and adalimumab. And if you are having predominantly an ischemic disease, which you can be assessed by FFA, then you can give anti-VEGF molecules, and even you can try the laser photocoagulation in the area of non-capillary perfusion. And you can try vitrectomy in case of if there is a complication such as tractional retinal detachment. This is a summary of retinal vasculitis I have taken from an article. So any retinal vasculitis, you have to rule out infection first. Infections include bacterial infections such as tuberculosis and syphilis should be ruled out in India, and other rare causes such as brucellosis, Whipple disease can cause retinal vasculitis. Viral infections are most common. Another most common area that can cause retinal vasculitis, especially HSV virus, varicella zoster virus, cytomegalovirus. These can cause acute retinal necrosis. So if you are seeing an acute retinal necrosis, always rule out viral infections and infectious etiologies at first, and parasitic infections such as toxoplasmosis and non-infectious causes such as systemic causes. This is where a rheumatologist usually come in cases such as Behçet disease, sarcoidosis, SLE, granulomatous polyangiitis, polyarteritis nodosa. And here you can see written as HLA-B27 associated uveitis, which is extremely rare. Usually HLA-B27 associated uveitis will not present as a retinal vasculitis. Among the HLA-B27 associated uveitis, psoriatic arthritis can have posterior involvement. So you should be careful if you are dealing with a psoriatic arthritis. And Sjogren syndrome, relapsing polychondritis, dermatomyositis, these are very, very, very rare. And another one of the rarest syndrome is the Susac syndrome, which can be present as a microangiopathy of brain, retina, and cochlea. Always remember malignant conditions, especially paraneoplastic syndromes such as cancer-associated retinopathy, melanoma-associated retinopathy, acute leukemia, lymphoma. And always keep remember that non-malignant conditions such as diabetes, systemic hypertension, atherosclerosis, branch retinal vein occlusion, branch retinal artery occlusion, central retinal vein occlusion, central artery occlusion. In that cases, if you are having a BRVO, BRAO, CRVO, CRAO, you have to rule out APS. And so if you are diagnosing an idiopathic retinal vasculitis, there should not be evidence of infection, malignancy, or any autoimmune disease. So this is another summary slide for retinal vasculitis. You have to take a detailed history first, whether the patient is immunocompromised or not, whether they are having any drugs which can precipitate retinal vasculitis, they are involved in any surgeries in the past which can present as retinal vasculitis. Then you have to examine the patient. Examination should start from anterior segment. Then you have to go for posterior segment. Then you have to do the imaging. Imaging include FFA, which is the gold standard. After that, you have to come up with which vessels are predominantly involved, whether they are predominantly having any artery involvement, vein involvement, or both, or capillaries. So if it is predominantly an arterial involvement, think about predominant infectious causes, that cytomegalovirus, infectious virus, acute retinal necrosis, and even other rare diseases like SLE, PAN, Church-Strauss syndrome, and Susac syndrome and all. If it's a predominant vein involvement, think about tuberculosis first, then sarcoidosis, Behçet disease. Behçet can be involved in all, can go artery, vein, as well as capillary and both. It's a variable vasculitis. So Behçet will be involved in all retinal vasculitis and other conditions such as toxoplasmosis. And if they are having a predominant capillary involvement, think about Behçet disease and ANCA-associated. And after FFA, you are identifying some occlusive vasculitis, then think about Behçet, tuberculosis, syphilis, SLE, PAN, and other things. Fundus examination is revealing predominant cotton wool spots, then think about SLE, GPA, PAN, Church-Strauss syndrome, cryoglobulinemia, infectious etiologies also. And retinal infiltrates predominantly, think about Behçet in infections. And necrotizing retinitis, think about infections at first, that is can cause acute retinal necrosis, toxoplasmosis, CMV retinitis, and HTLV associated retinitis. And if you are seeing a retinal ischemia, think about tuberculosis, Behçet, sarcoidosis, perivascular choroiditis, any choroidal involvement, think about tuberculosis. And aneurysmal, they are seeing aneurysmal dilatation of retinal vessels, think about Irwan. And you are seeing frosted branch angiitis, that means some part of the retinal vessels are inflamed and it is giving an appearance of a frosted branch. Then think about viral infections, and immune complex deposited autoimmune disease, leukemias, lymphomas, and all pathologies. As a summary, as a rheumatologist point of view, you have to always rule out sarcoidosis and Behçet. If your evaluation is all evaluation is coming negative, you can plan genetic testing to identify any rare modalities such as TREX1 associated vasculopathy and all. That is very rare. Let's summarize investigative approach. If you are seeing an infectious sign, you can do PCR for the infectious pathology such as HSV, varicella zoster, toxoplasmosis. You can also do serological testing and tuberculin skin test or Mando for if you are suspecting tuberculosis. You can do ICRA and CyTB also. If you are suspecting an autoimmune disease, you can order ANA and ANCA if you are suspecting an SLE or GPA. Never order these tests if you have no other clinical signs or suggestive of this disease. And if you are suspecting Behçet disease, you can order HLA-B51 and you can also do pathology test. And you can also send serum ACE level and take a chest X-ray or CT to rule out sarcoidosis. And if you are suspecting tuberculosis, you can even do PCR and IGRA. They are having some atypical or refractory retinal vasculitis. To treatment, you can think about proteomics and HLA typing for deeper understanding of the disease, as well as you can do cytokine profiling also. So with this, I'm concluding my talk on retinal vasculitis. I hope everyone enjoyed this session. If you like this video, like and subscribe and share with your fellow medics. So bye and see you on the next session.